right, thanks. All right, well, welcome everyone. It's great to see all of you here today, again in our virtual space. We want to welcome you to another presentation in our All About Alzheimer's monthly series, where we just, again, hope to bring you useful information that you can take back with you to your respite and support groups, or those of you who might be caring for family members or others. And we hope this information is useful for you as well. It's a pleasure to be here with you again. I'm really enjoying this series so much and getting to know many of you. For those of you I haven't met, my name is Joan Asseff, and I'm a licensed clinical social worker here in the state of Texas. I've spent most of my career working with older adults in a wide array of settings, including skilled nursing, hospice, home health, psychiatric care settings, and private clinical practice. So I feel very fortunate to have been in those many settings. And I now teach clinical social work practice at the Steve Hicks School of Social Work at UT Austin. So I've worked extensively with individuals and caregivers going through the extreme challenges of Alzheimer's disease and other dementias. And I want to recognize, of course, the selflessness and painstaking work that all of you do in various ways to support those impacted by this very difficult disease. So with that, we'll go ahead and get started. And as you know, we're recording this session, so you'll be able to view it again later. It'll be available to you on the Alzheimer's Texas website. As usual, we always want to make a quick note about Alzheimer's Texas before we get started. As I'm sure many of you know, Alzheimer's Texas is an independent local nonprofit that used to be known as the Alzheimer's Association, Capital of Texas chapter. They have been privately funded and a voluntary health organization since 1982, serving Central Texans with Alzheimer's disease and their caregivers. So about 3 or 4 years ago, Alzheimer's Texas broke away to form their own nonprofit and decided to focus 100% of their funds and their efforts here in Central Texas. However, Alzheimer's Texas maintains the same level of commitment, providing support, education, like today, and what you're hearing today, and advocacy for those affected by Alzheimer's and other dementias in our community. Currently, Alzheimer's Texas reaches about 12 to 16 counties, though the pandemic has allowed them to reach a broader population in Texas through virtual platforms like the one you're participating in today. So Alzheimer's Texas continues to carry out its vital mission to eliminate Alzheimer's disease and related disorders through the advancement of research and to enhance care and support for individuals, their families, and caregivers. So thank you again for being here today and supporting this mission through your participation. So, of course, like any good academic, I always bring learning objectives. I don't know how to give a presentation without learning objectives. So I'd like to briefly go over these, but before I do that, I also want to really emphasize good self-care for those of you who are here today and for those of you who may be listening later on. I will be covering some especially difficult topics today, such as methods for end-of-life planning in terms of advanced care planning and so forth that may be difficult or triggering for some people. So feel free to take a break if you need to. If you need to exit the presentation at any time and come back if you can, that makes total sense. And mainly, I just want to make sure you take good care of yourself as we go through this information. So with that supportive reminder, today we want to understand how to complete commonly utilized advanced directives in Texas. We want to learn how to utilize advanced directives during a medical event. How are these documents important as we go through our healthcare experiences? And then identify strategies for facilitating advanced care planning decisions and discussions. And of course, as always, we want to think about and share ways we are supporting ourselves and or caregivers to better prepare for end-of-life care decision making. So those are our overall objectives. in this presentation today. As we begin to discuss the topic of advanced care planning, it's helpful to have some basic common definitions to work from. As many of you probably already know, advanced care planning is the process of planning for your future care, essentially. Advanced care planning involves learning about the types of decisions that might need to be made, considering those decisions ahead of time, and that's really the key feature, right? And then letting others know, both your family and your healthcare providers, about your preferences for your care. Advanced directives, such as a medical power of attorney and other documents that we'll go over today, are documents that state your choices for healthcare or name someone to make those decisions if you are unable to make your wishes known in the future because of illness or injury. And finally, a healthcare proxy, and we're going to talk more about this, is a healthcare agent or person chosen by the patient. This is someone trusted by the patient to act on their behalf if they are unable to make the healthcare decision or communicate their wishes at that time. Okay, so those are just some basic definitions to kind of focus us today and give us some common language. I want to be clear about the fact that this topic, advanced care planning, is for all people of all ages and health status. While I know most people attending this presentation are supporting people living with dementia and or other diagnoses, advanced care planning is important for young and older people alike, regardless of their health status. And I want to be, really clear about that. Making these important decisions in advance means that family members won't have to make every difficult decision in the future without the person's guidance, without the patient's guidance. We know that a dementia diagnosis renders these decisions even more important and makes them even more time sensitive because of the progression of that disease process. In my hospice work as a social worker, I met with many family members who expressed sadness and regret that their loved one had not communicated what they wanted for their care prior to their health event and their health decline. Having these decisions and these decisions made and having these discussions is just as important as your annual checkups with your doctor or routine health screenings that we participate in. So I'm very glad you're attending today or viewing this presentation today. As you think about these decisions, of course, for yourself, I think about them for myself, and as you think about how to support others in making these decisions. As you begin to complete or consider updating your or your loved one's advanced directives or supporting someone in completing these advanced directives, it's important to review various medical terms and procedures and to discuss them with a healthcare provider. Again, in my role as a social worker, I always advocated for doctors and nurses to take time to explain these terms to patients so they could make informed decisions about their health care. These are very complex terms, and there can be a lot of confusion around these terms. I encourage everyone to take time to do this research for themselves and support those you're caring for or the clients that you work with to do this research as well. There can be, as I mentioned, misconceptions or misunderstandings about these terms, and I will touch on a few of those misconceptions today as we go through this information. We don't have time today to cover all of these definitions, but I have provided a list of these terms and definitions at the end of the presentation for those who wish to review them. These slides will be available on the Alzheimer's Texas website, and some important terms to pay attention to for today's presentation include do not resuscitate orders, medical power of attorney, and directive to physicians, otherwise known as a living will. And so we'll go over those in detail in just a few moments here. So there are various types of advance directives in Texas, both financial and medical, but we will be covering the three most commonly completed and utilized advance directives in this state. Since this presentation is focused on advanced care planning for healthcare, we will not cover advance directives related to financial planning, such as the statutory durable power of attorney. For financial planning, I always recommend that folks speak to their banking institutions, their lawyer or legal representation, financial planner, and or CPA for assistance. So with that, we'll take a deeper dive into each one of these advance directives. All right, so many of you are likely familiar with the medical power of attorney, but I'll provide what I hope will be some helpful detail for those of you who may be familiar with it, but you've never really spent a lot of time kind of examining the various sections and aspects of this advanced care planning document. By far, and I used to tell families and patients that I worked with, by far the medical power of attorney is the most important advanced care planning document a person can complete. This legal document names a healthcare proxy or someone who can make medical decisions for you at times when you are unable to do so. This person can talk to your healthcare providers and make all decisions related to your healthcare. This person should be someone you trust, obviously, and someone who is very familiar with your values and your wishes for your healthcare. A medical power of attorney can be chosen in addition to or instead of a living will or a directive to physicians, which I'll go over in just a few minutes. So if that sounds a bit confusing, just know you'll have more information later in the presentation. So in other words, you can have a living will or a directive, which is also called a directive to physicians, and a medical power of attorney completed for the same person. And again, I'll go into more detail about that in just a few minutes. Now, I've talked about some of the misconceptions that are out there, and here is one of them. People often believe that signing a medical power of attorney means that you have given up your right to make your own healthcare decisions. And I have folks in my own family who right now believe that and don't wish to complete these documents. This is absolutely not true. A medical power of attorney does not go into effect until a person becomes unable to make their own healthcare decisions. And this fact must be certified in writing by a physician. When I worked in healthcare for many years, I often worked with patients who had a designated medical power of attorney, but they were still able to make their own healthcare decisions, and they readily did so with no complication and no limitations. A medical power of attorney can also be revoked or changed at any time. So completing one of these documents does not mean that this decision is set in stone. I've worked with many patients over my career who decided to revoke or change their medical power of attorney for various reasons. Maybe a person's medical power of attorney moves to another country, or sadly sometimes passes away. There are many reasons, again, why someone might make this change, and it's very straightforward to do so. Since the medical power of attorney can be completed without the healthcare proxy or the person you've selected being present, it's very important to inform the person you're designating as your medical power of attorney that you are doing so, and make sure that they are comfortable and willing to fill this role, because it is a very significant responsibility, of course, to take on. It's important to review this document with both your designated medical power of attorney and your physician, and provide both with signed copies. So as I mentioned, just to reiterate, it's important to discuss this document with your physician or other healthcare provider before signing it, to ensure that you understand the nature and range of decisions that may be made on your behalf. You do not need, and this is another misconception, you do not need a lawyer's assistance to complete this document, though Many people do choose to have legal assistance or a lawyer's assistance with completing this document, but it's not necessary. However, if there is anything in this document that you don't understand, you should ask a lawyer to explain it to you. The person you appoint as your agent should be someone, again, you know and trust, and they must be 18 years of age as well or older. If you appoint your health or residential care provider, for example, if you wish to appoint your physician, a physician, or an employee of a home health agency or any other health entity or institution, that person has to choose between acting as your agent or as your health or residential care provider. The law does not allow a person to serve as both at the same time. And this is just a really important reminder because, of course, if you trust your home health nurse and you really would like for that person to be your medical power of attorney, they cannot actually serve as your home health nurse and your medical power of attorney. So just really an important point to keep in mind. Serving, of course, in both roles is considered a conflict of interest. You also want to indicate on the document itself the people and institutions that you intend to have signed copies. And we will look at various sections of the medical power of attorney in just a few minutes, so you'll see those sections. As I mentioned, you have the right to revoke the authority granted to your agent by informing your agent or your health or residential care provider orally, so you can just say it out loud. And I worked with patients that did this, where they said, I am revoking my medical power of attorney. That person is no longer my medical power of attorney. You can also do it in writing, of course. And then you can execute a subsequent medical power of attorney form to name a new healthcare proxy. So it's not complicated. Again, you can just simply tell your healthcare provider that a person is no longer your healthcare agent, and you can change that document. It's also important to note that the most current medical power of attorney is the valid form. If two medical power of attorney forms exist, the older form is null and void, and the newer form would be honored. And I have seen this in healthcare practice where two medical power of attorneys show up with two documents, and we have to look at those dates to determine which medical power of attorney is most current. Once completed, the medical power of attorney document, they may not be changed or modified. If you want to make changes to this document, you must execute a new medical power of attorney. You may wish to designate an alternate agent in the event that your agent is unwilling, unable, or ineligible to act as your agent at the time that you need them to do so. If you designate an alternate agent, the alternate agent has the same authority as the primary agent to make healthcare decisions for you. Okay, that's a lot of detail, but important information. All right, so let's take a closer look at a few important sections of the medical power of attorney document. As you see here, a person can place limitations on the decision-making authority of their healthcare agent. For example, a person could state that their medical power of attorney can only make healthcare decisions related to their physical health, but not their mental health. In practice, I will share with you, I have seen most people leave this section blank because it's hard to predict exactly which types of decisions your medical power of attorney will need to make in the future. Placing limitations on the medical power of attorney can make it more difficult for them to carry out various wishes and to provide, or facilitate care in various settings. So just something to keep in mind with this document. All right, so this is another section here. As I mentioned before, a person can name a primary and an alternate medical power of attorney. This is generally a good idea because you never know what can happen in life, as we all know. I have seen situations where a patient and their primary medical power of attorney are both in the hospital at the same time, possibly because they were in a car accident or something like that. It makes sense to have another person named to ensure that your wishes are carried out, even if your primary medical power of attorney, they may not be available to fill their role at the time that they need to. So it's really helpful to have a backup medical power of attorney named. And also, it's very important to list where you will keep the signed copies of the document, as we mentioned. And I will say this is an important step for all advance directives, not just the medical power of attorney, of course. As many of you know, it's very difficult in the middle of a health crisis or event to be looking through closets or your laptop files, filing cabinets, and so forth, trying to find these vital documents. So later in the presentation, I'll cover some tips for making sure loved ones can easily access these documents when they need to do so. I want to take a few moments to discuss the signing of the medical power of attorney document. This is where often there was a lot of confusion and mistakes that led to these documents not being valid within the practice settings that I was in. You can absolutely have the document notarized, which is a pretty straightforward way to complete the signing portion. And you would not need 2 witnesses if you have the notary. It's also perfectly legal and fine to have 2 witnesses sign the document after they visibly witness the patient sign this document. However, there are some very specific and important restrictions on who can witness the medical power of attorney. If these are not followed, the document could be rendered null and void at a later time, which I have seen happen, that there's question about the witnesses, and so the healthcare institution or setting does not feel comfortable honoring it. The witnesses cannot be related to the person by marriage or blood. They cannot be entitled to any portion of the person's estate upon their death. They cannot be the attending physician or an employee of the attending physician, or involved in providing direct care to the person, an officer, director, partner, or business office employee of the healthcare facility where the person is receiving care. That is a lot. Those are a lot of restrictions. This was always a challenge for me as a social worker assisting patients and families with advanced directives in healthcare settings. Often patients and families would say, "Can't you just witness this document for me?" And I would have to explain why I could not serve as a witness. It's a good idea to think ahead about who you would like to witness this document and other advanced directives, such as a neighbor or family, friend, and ask those persons to be available for the signing of the document. So it takes some planning. And I used to tell folks that, in the settings where I worked, we're probably not going to be able to get this done today because we're going to need to access some witnesses. Sometimes we could, sometimes it would take a bit longer. All right, now we want to touch on another very important advanced directive document, the Directive to Physicians and Family or Surrogates. That's a long name, also commonly referred to as the living will. The Directive to Physicians, which I'll use for short, is a legal document that allows you to direct physicians to administer or withdraw life-sustaining treatment when you have a terminal or irreversible condition and are unable to speak for yourself. You may also specify which treatments you would like and which you would not, such as tube feedings, dialysis, IV treatment, and so forth. This form allows you to consider your healthcare wishes based on your personal, cultural, and spiritual values and beliefs. And that's a really important reason for completing this form. It really conveys what you would want from a very personal and value-based perspective. This document helps you and your loved ones consider what burdens, what hardships, medical experiences, and treatments you would be willing to accept for a particular amount of time and a particular amount of benefit if you were seriously ill. You do not need a doctor's assistance to complete this document. But you should ask your doctor. I usually recommend that folks do ask their doctors to explain various treatments and procedures and discuss your personal values and preferences with your healthcare team. Again, there are many misconceptions about various treatments, so it's important to get accurate information from a physician or another healthcare provider about what exactly the treatments entail. It's also, of course, important to periodically review this document. Our preferences for our care can and often do change over the course of our lives and as our healthcare status changes. So it's really important to take a look at this. You might feel differently 10 years down the line about which procedures you would be open to. And as with all advanced directives, you want to indicate on the document itself, of course, the people and the institutions that you intend to have signed copies, as I said before, and you have the right, of course, to revoke this document and execute a new one at any time. One very important and I believe confusing fact is that this document does not take the place of an out-of-hospital do not resuscitate order, which I will go over in just a few minutes here. So keep that in mind. You can complete this document, but in the state of Texas, for a healthcare professional to abstain from CPR, you must have an out-of-hospital do not resuscitate order. And I'll go into more detail about that in just a few minutes. All right, I think that's everything that I wanted to share with you about the Directive to Physicians. I'm going to take a snapshot here at a few sections. I want to take a brief look at some important parts of this form. As you can see here, each person can indicate what they would want their physician to do if they were in a terminal condition or an irreversible condition. It's important to note that these designations do not apply to hospice care. When a patient or healthcare proxy opts into hospice care, it's generally understood that the patient will receive comfort care only, and life-sustaining treatment will not be administered unless the hospice care is revoked, which certainly it could be. But that's really an important detail to keep in mind. As you can see here, each person can list specific treatments they would or would not want, and specific scenarios in which they would or would not want them. For example, a patient might state, I would only want dialysis for short-term treatment, but not for long-term treatment. The same type of instructions could be given for a feeding tube or intravenous treatments. A person does not have to complete this section of the Directive to Physicians, but it is an opportunity to be very specific about treatments you would or would not want. Many of us have heard from friends or family members about treatments that they would not want. And a Directive to Physicians form is the best way, really, to make sure that those treatments are not administered. And that everybody knows that the person would not want those treatments administered. If a person does not have a medical power of attorney designated, they can name a healthcare agent and alternative agent on the Directive to Physicians form. So they can do that here. However, it's important to avoid having both a medical power of attorney form and then accidentally designating someone different as your healthcare agent on the Directive to Physicians form, which I have seen. So you just want to make sure that if you have both of those forms, that the healthcare agents that you designate are consistent across the two forms. Otherwise, there can be a lot of confusion, of course, when it's time to identify who the primary healthcare agent is, if there's an inconsistency between these two forms. I didn't see that mistake often in my practice, but when I did see it, it was a big problem. All right. And then finally, just a quick reminder that just as with the medical power of attorney form, this form has the same specific restrictions on who can witness it. I have listed these here again just for your reference. For some reason, this form in Texas only can be witnessed and does not have a section for notarization for a notary, and I'm not sure why That difference exists, but this form really only has the option for 2 witnesses. So just to keep that in mind as well when you prepare, for the signing of these documents. All right, now, last but not least, and certainly have other things to share, but in terms of going over these 3 documents, the out of hospital do not resuscitate order is one that I think there is generally more confusion about, and is one that really has to be closely reviewed by patients, families, and healthcare institutions to make sure that it is executed, both completed and executed properly. So with that, I want to be clear that this form is technically a physician's written order instructing healthcare providers to not attempt cardiopulmonary resuscitation, otherwise known as CPR, transcutaneous cardiac pacing, defibrillation, advanced airway management, and artificial ventilation. And why am I listing all of those? Well, it's because those are the exact procedures listed on the out of hospital do not resuscitate order. This order basically asks healthcare providers to abstain from those treatments that would restart a heart that has already stopped beating. And that is often how I described this form to patients and families in healthcare settings where I was providing that education. This advanced care planning option is often utilized by patients and families who are faced with a terminal condition where CPR would likely not be effective or would render the person's condition worse if resuscitated. While this is a vital procedure and an incredible tool, incredible life-saving tool, CPR is a very physically aggressive procedure, as many of you know. Patients can sustain broken ribs and punctured organs during this procedure, which is, certainly worth the risk if a patient has a reasonable quality of life or the ability to heal from those injuries. If this is not the case, many patients or family members will consider the out of hospital do not resuscitate option, indicating that they would not want those procedures implemented if their heart has stopped. Some healthcare providers and patients have started referring to this advanced directive as allowing natural death, because that is essentially what this form allows for. And that, I think that term is much more descriptive and reflective of the process at hand when this form is utilized, rather than what can feel like not providing essential treatment. So it really means that there will be no intervention given when the body is naturally shutting down due to an incurable disease process, that those life-sustaining treatments will not be implemented. There are several parties who can legally complete this form, including the patient, the legal guardian, the medical power of attorney, of course, a healthcare proxy, spouse, adult child, parent, nearest living relative, or 2 physicians signing together if none of those aforementioned parties are available. Now, I want to return to some of those misconceptions that we talked about. Some people worry that signing an out-of-hospital DNR means that they are giving up or that they won't receive curative care. And I can absolutely understand why those perceptions are out there. However, executing an out-of-hospital DNR does not prevent a patient from receiving comfort care or curative treatments. For example, if someone with an out-of-hospital DNR wishes to pursue cancer treatment, they can absolutely do that. So this document does not prevent any type of treatment except for those life-sustaining treatments outlined in the document itself. It only pertains, again, to that cardiac resuscitation, not dialysis, not other forms of curative or life-sustaining care. As with other advance directives, it can be revoked orally. You can simply say, I don't want that document in effect anymore, or in writing at any time. Although the out-of-hospital DNR order is written at the request of the person or their family, it must be signed by a physician to be valid. And I want to be very clear about this. It is a physician's order. An out-of-hospital DNR order is written for individuals who are at their home, not hospitalized. So it's for folks who are in a home setting, not an inpatient hospital setting. And it does not apply to care provided in the hospital. Additional doctor's orders must be written in the hospital setting. And they usually, if not always, are written in the hospital setting. The method for completing this document, as I mentioned before, varies depending on the capacity of the patient, and the signers should closely read all instructions prior to signing. This document I find to be especially confusing, and you'll see how tiny the print is and how many sections it has. And I see some nodding heads, and a lot of you have already gone through this process and know what I'm talking about. We'll take a closer look in just a few moments. Most importantly, this document, and only this document, allows emergency medical professionals, EMS or other emergency healthcare professionals to abstain from CPR outside of the hospital setting. Even if a person has indicated on their directed to physicians form, their living will form, that they would not want CPR, they must also execute an out-of-hospital DNR order for healthcare providers to be able to legally abstain from CPR and the other procedures that I mentioned that are on this form. Otherwise, these healthcare providers, these emergency healthcare workers, they must and they will try to resuscitate someone. I have seen EMS workers start CPR on folks who have completed a directive to physicians, indicating that they didn't want CPR, but because they didn't have that out-of-hospital DNR, those emergency workers did not have a choice in that moment. They have to err on the side of saving someone, if you will. This document must also be made readily available to the emergency responders to be honored, which is why healthcare providers recommend that it be posted by a person's front door, especially if they live alone. I know one woman in my neighborhood who keeps her out-of-hospital DNR in a waterproof pouch that she wears around her neck when she goes for walks, because she is that serious about it being honored, which I certainly respect and think is a great idea. So it really does have to be made readily available to the EMS worker to be honored. And that's an important detail that many people I worked with over the years, just they weren't aware of, which is understandable. Now, as I mentioned, and as you can see, the print is tiny, and this form can be quite confusing. There are several sections on the out-of-hospital DNR, and again, it's tiny. I get your magnifying glass or your glasses out. I recommend that patients and families read the entire document very closely to make sure you are completing the appropriate section and signing in the appropriate places. The document can be witnessed by 2 competent adult witnesses, or it can be notarized. In terms of the witnesses and how to execute the out-of-hospital DNR, there are very specific definitions and instructions included in this document. And I'm not going to walk you through all of them today, but I just recommend that anyone executing this document read all of those instructions very carefully. If it isn't completed properly, a healthcare provider has the right to reject it and to initiate CPR or those other procedures listed in this document if they believe that it was not completed properly. And unfortunately, I have seen that occur in various healthcare settings as well. Again, they're always going to err on the side of saving lives if there is any uncertainty about this document. Each person who signs the document must sign it twice. And that's another detail. I've seen these completed where someone signed just once, but they didn't sign again at the bottom, and that made the form invalid. They must sign twice, and that second signature is at the bottom where it says all persons who have signed above must sign below, acknowledging that this document has been properly completed. So just another important detail to keep in mind when working on this document. Okay, let me back up here. Let's see. I jumped ahead there for a minute. Okay. So once you have these vital documents completed, how do you make sure others can access them when they need to do so, right? That's the really important time. Here are a few tips to make sure these documents are accessed by those who need them when they need them. It's important, of course, to provide copies to all of your healthcare providers and those involved in your healthcare, your family, friends, caregivers, maybe folks in your faith community that are involved in your spiritual care. Whoever you think needs to have a copy, feel free to provide them with one. If you or a loved one admits to the hospital, you want to provide these documents to the healthcare team immediately. People used to say, oh, well, maybe I'll bring them in the morning. I'm really tired tonight. You want to get those documents there as quickly as possible because a patient's condition can change quickly. And if those documents are not present, then the healthcare team, healthcare providers are unable to act on them. As I mentioned before, it's a good idea to carry copies of these documents in your car, in your purse, in your wallet, whatever you carry around. Then you don't need to go home and get the documents if you already have them, close at hand. Since these are vital documents, it's a good strategy to keep them in a safe place within your home and somewhere on your electronic devices where you can find them easily, right? And not kind of buried under 20 files where you're like, where is that document? Somewhere that's just really obvious on your electronic devices. When I worked in assisted living and independent living communities, we often recommended, and I know this will sound strange, but that people put these documents potentially in their freezer in a waterproof container, which I know again sounds strange, but that's a really easy place to remember and likely to be fairly fireproof as well. Of course, a fireproof safe would be just as effective, and a lot of people use that option. And then finally, it's very important to tell family members and friends where these documents are located. My stepfather used to tell me all the time where a copy of his will was located. And he was only in his 50s, and I thought, well, this is so strange that he keeps telling me this, where this will is located. Now that I'm older, I definitely understand why he wanted me to know, because in times of crisis, you don't want to wonder where are these documents and how can I find them? So I have a much greater appreciation for that conversation now. All right, so now many of you might already have some or all of these forms completed for yourself or for your loved one. However, you might just be starting to think about completing these forms and having these conversations with loved ones, or you might be supporting folks that are involved with the agency that you work with or where you serve. You might be supporting others in having these conversations. In healthcare, we always say it's easier to have these conversations when you are not experiencing a healthcare event or crisis. And some of you might have shared similar sentiments with those you work with or with family members. It's much harder when you're under the stress of an unexpected or sudden change in health status. So these are some helpful strategies outlined in a wonderful resource that I often utilize called the Conversation Project. Some of you may be familiar with this project and with these resources. I'll share more about this helpful resource and others in just a few minutes. But here you can see some of the language to help patients and family members and loved ones begin to have important advanced care planning conversations. For example, referring back to when someone else in the family died and impressions of what that experience was like, or recognizing that you're okay right now, but I'm worried about my health changing, and what I might want to plan for in the future. And so you can see some of the language here that is really helpful in initiating these conversations. If someone is struggling to find ways to start these conversations, these are some really great suggestions. And I've used a lot of this language in my work with patients and families. The Conversation Project also provides a great list of exactly what to talk about. I mean, really gives you an exact checklist. They include questions like, when you think about the last phase of your life, what's most important to you? How would you like this phase to be? Other questions like, where do you want or not want to receive your care? In your home, in a nursing facility, assisted living, or hospital? These types of questions help families begin the conversation, help patients begin the conversation about their preferences, which really is the first step in completing advanced directives. This guide also includes helpful reminders, such as being patient, which is really important. Some people are going to need time, of course, to think about and reflect on these decisions. And remembering that we don't have to steer the conversation. Others in the family can also, or others in the agency can help steer the conversation. And the conversation can happen organically. As it says here, every attempt at a conversation about advanced care planning is valuable, even if decisions aren't made at that point in time. And they might be the first of many conversations, of course, and usually they are. All right, like any good social worker, I've given you a ton of resources to take with you. And again, this information will all be available on the Alzheimer's Texas website. Here's a picture of the resource that I referenced, the Conversation Starter Kit, along with a list of other resources that can help patients, families, friends, and healthcare providers plan for and have important advanced care planning conversations. This list was actually put together by the Centers for Disease Control, and there are more resources listed on the next slide as well, including the toolkit provided by Texas Health and Human Services, and that is the Thinking Ahead, My Way, My Choice, My Life at the End toolkit. So I wanted to include that reference here as well, and some other great resources. So the good news is there are lots of tools, lots of resources to support both, supportive agencies that are helping others in this process, and patients and families who are going through this process. And with that, we will wrap up and open the floor for questions, sharing of experiences and stories, maybe in the work that you've done